We're here today with Dr. Jeff Linder, the Chief of the Division of General Internal Medicine at Northwestern University, Feinberg School of Medicine. Jeff, thank you for joining us today.
Thanks, Jordan.
So for those who don't know, Northwestern Medicine is a health system headquartered in Chicago, Illinois, with 2,700 inpatient beds and 11,000 providers across 12 hospitals and other ancillary facilities. There are many topics we're going to cover today, from antibiotic stewardship, telehealth, digital front doors, EHRs. But I'd like to start with antibiotic stewardship. It's a topic you've published extensively on and are known for. I understand, Jeff, that you are on the Presidential Advisory Council on combating antibiotic-resistant bacteria. Is that right?
So I've presented to that group. So
okay, great.
I was not on the council itself, but have presented to that group among other groups, but on other advisory committees at HEDIS and the Joint Commission and NCQA.
Excellent. So what I'd like to ask you to kick off this conversation is, how is Northwestern using technology platforms today to reduce overprescribing of antibiotics?
Yeah, I think the main thing is using our information systems to generate better feedback. So I've been working with behavioral scientists, social psychologists, and behavioral economists over the past, it's getting towards 15 years now, about how we change prescribers' behavior. And one of the first areas we did this was around antibiotic prescribing. And so we are using our enterprise data warehouse and the EHR to generate kind of simpler reports about how individual clinicians and clinics' antibiotic prescribing is, and feeding that back to them.
And so I think it'd be interesting to our listeners if you were to walk us through a particular use case where you saw maybe a cohort of providers or an individual provider who was just potentially prescribing way more antibiotics than are clinically indicated as having been necessary, and then kind of what the intervention was, and then what the outcome was, if you would.
Yeah, so we have a paper about antibiotic prescribing in our immediate care centers. So that's the Northwestern Medicine urgent care centers. And like a lot of urgent care centers, the antibiotic prescribing rate was, to put it nicely, suboptimal for respiratory infections. I mean, in their defense, like 50% of the visits they see are for respiratory complaints. And so they get scored and rated on patient satisfaction and throughput. So it's challenging. I don't want to understate the challenges of doing well while you're doing right by the patients. And so we developed a EDW report that we fed back to clinicians in our immediate care centers. And the thing we were very focused on initially was clearly inappropriate antibiotic prescribing. So we could, and the generalizable message here is, if you can, right target. So, this was antibiotic prescribing for colds, the flu, acute bronchitis, where the patient kind of had nothing else going on. And we knew that the top performers among our immediate care clinicians had an inappropriate antibiotic prescribing rate of 0%. And then we compare, how everybody else was doing relative to the top performing doctors. And so this is how you're doing relative to the top performers in your clinic. And by giving people that report, we reduced the inappropriate antibiotic prescribing rate sort of from the 30 to 40% range over the course of about 1.5 to 2 years to like 10%.
Wow. And just to be clear, these were, so the top performers, they had 0%. They were never prescribing antibiotics when it was not needed, but they were prescribing it when it was needed. And then there were other providers who were prescribing it many times when it was not needed, and they were able to reduce the times when they inappropriately prescribed it, correct?
Correct. And, this gets, it gets really complicated in a hurry. And so as a first pass, we're just trying to eliminate very clear inappropriate antibiotic prescribing. But, there's two things happening there. There's a diagnosis selection, and then there's an antibiotic prescription. And so, you could easily, if you were, I have another colleague, so Mark Friedberg, who's at RAND, who refers to if you were an evil-doing, metric defeating clinician, it's not hard to figure out, like, okay, now everybody has pneumonia, and I never diagnose anybody with a non-specific upper respiratory infection, aka a cold, then we've eradicated the diagnosis of the cold, but we've not changed the antibiotic prescribing rate. Like, that's not victory. And so you actually have to be clear about the target of your intervention and then expand the basket of diagnoses you're focused on a little bit to make sure you're not seeing that diagnosis shifting on the part of clinicians.
Did you ever have underprescribing, meaning that what they should have been prescribed but were not?
We did not see that. In a number of studies, we have not seen underprescribing. And we've also done studies looking at, do people with that narrow inappropriate diagnosis group, do they, when we shut off antibiotic prescribing in that group, do we see more ED visits, hospitalizations, follow-up clinic visits? And we never do.
So on the topic of changing provider behavior over the course of a year and a half, you said you compare providers against top performers in their same clinic. So was the solution merely printing out this report, physically booking 20 minutes of time to sit with them at a table in chairs and say, here's you, here's everybody else, here's you, here's everybody else? Or were there clinical decision support tools like a best practice advisory alert that would pop up? I mean, was it a combination of all the above? How did you actually go about changing that behavior?
It was more the former. So we actually had, Catherine Ritter, who's a colleague is an urgent care doc, and you need a champion who does the kind of care where you're trying to change the behavior. Because if I show up, I'm a general internist, they say, well, you're a primary care doctor, you have no idea what it's like. And, all of those, that's one of the defense mechanisms. Like, these data don't apply to me, and I'm hearing about this from somebody who doesn't understand my life. And so we had Catherine Ritter, who's a card-carrying urgent care doc, visit the different practices. We also have an ambulatory antibiotic stewardship team that would feed back. So in that respect, the actual intervention itself is much more social than technical. So we need the technical stuff to be able to get the data, but the loop is closed sort of with the social aspect of it. And to be clear, to put too fine a point on this, maybe. I mentioned that a lot of this was designed with behavioral scientists and social psychologists. The idea of showing you how you're doing relative to your peers and your top performing peers is key. A lot of times we think about putting more information in the EHR, and I would argue we actually have too much information in the EHR and not enough good information. But actually what we were, nobody's prescribing antibiotics for colds because they don't know they shouldn't do that. They're doing it because of other things. And so we have to, other pressures, time pressure, patient satisfaction pressure, patient expectation pressure. And so you have to meet that perceived pressure with kind of the peer pressure of, doing the right thing by patients, and that this is an organizational imperative.
So I'm a doctor in an ambulatory clinic, and I've been prescribing at a rate 30% higher than is clinically indicated as being appropriate. And I have my sit down with the doctor from the ER that you just said, and she really convinces me that I've been doing the wrong thing. Oof. Yeah. Okay, I'm on board now. I'm going to do the right thing, except hold on a second. I still have 23 patients to see a day, and patients are still coming in saying, I'm sick, I need antibiotics. And I got to say, no, you don't. But how do I manage the time and the patient satisfaction, all the other pressures and the direct to consumer pharmaceutical marketing that says, patients are coming in demanding these things. How do I handle these things now that I know what the right thing is?
Yeah. And I'm glad you asked, because we also, we're not just coming at the clinicians with shame, right? So we also try to give them tools, so communication tools and efficiency tools, where we want people to be able to do this efficiently, leave the patient satisfied, and do the right thing, and make the case that you can do that. So we did have, you can look at our, if you dig around our website, which is ASP, so Antimicrobial Stewardship Program, asp.nm.org. And God help you if you watch it. There's a video of me sort of demonstrating, quick, highly rated communication skills with patients, so you can do this quickly and efficiently, and leave the patient happy too. And others have done work in this area too. So Rita Mangione-Smith. And then another intervention we've used over the years is commitment posters. So putting up in the waiting room, ideally signed by and with a photo of the clinician in there, saying, we are dedicated to doing the right thing for you and only giving you an antibiotic when it's absolutely necessary before the visit. And the action from those posters is probably more in the clinician's mind than anywhere else, right? So the clinician knows that the patient knows that the clinician has already pre-committed to doing the right thing. And so you're trying to short circuit that clinician's presumption that, oh, the patient is here to get their Z-Pak.
Got it. So now we know what we need to do. We know how to do it. We're all ready to march forward. Let's look a bit into the future. We've now, had a year or a few years of time has passed where we've been successfully reducing the amount of inappropriate antibiotic prescription. What's the outcome clinically? I mean, obviously you're prescribing fewer, but, is it too small of a sample size to say, hey, we've had a reduced risk of MRSA, reduce hospital-acquired or infections? Is there any kind of positive health outcome? Because obviously you're looking at a societal level.
Yes.
With antibiotics in the food stream and everything, there's a lot of problems with the lack of efficacy of antibiotics. But just at Northwestern, can you evaluate outcomes?
Yeah, I think it's a couple things. And so for your listeners, getting the HEDIS measures about avoiding inappropriate antibiotic prescribing for acute bronchitis, and then actually the HEDIS measures have broadened in the past couple years to reducing overall antibiotic prescribing. So insofar as that is a quality target for your listeners, I would encourage them to look at HEDIS measures, and then they can go back to payers and say, look, we're doing better at this. So that is a very concrete thing you can do. And I wouldn't discount the satisfaction that clinicians get from being able to do this. Like, I've talked to a lot of people over the years clinicians that have kind of done a 180 in their antibiotic prescribing, and they actually kind of like feel better about it because they knew they didn't sort of care. And so there's a clinician satisfaction aspect of this as well.
Now, on this topic, there's a few segues that we can go into. One is there any telehealth or digital front door component to reducing overdiagnosis and overtreatment, or is it mostly kind of when patients present in a physical clinic?
Yeah, great question. A lot of, and I can take that a couple different directions. Let me try to take it maybe two, but 100% that you can make the argument that by the time the patient gets into the exam room with the doctor with a cold, like, too late. We've missed a huge opportunity in triage to say, by all rights, it sounds like you have a cold or you have a cough and you don't have any other comorbid illnesses that we're worried about. And so it is to a certain degree like a failure of triage. And so building up better triage capabilities, and this is an imperative more in primary care than urgent care. So urgent care, we want to get people in who want to be seen, see them quickly, leave them happy, do the right thing. Primary care, we have such a demand for seeing patients, and acute respiratory infections make up about 10% of all visits to primary care. And most of those, you could, in some respects, look at that as waste. And so doing better triage and keeping people at home with symptomatic treatments and kind of avoiding the visit in the first place is actually improving access in primary care. So we're definitely doing that. And then the second place I wanted to take this was I actually just got funding along with a colleague, Julie Simsack, who's at University of Utah. She's a sociologist, to study patients who make lots of these visits. And so just to pick off the patients who make 4 or more visits for inappropriate antibiotics over the course of 18 to 24 months and actually go right to them and say, because we always hear from doctors that, oh, it's the patients that want the antibiotics. And you really need to talk to the patients. And so in this project, we kind of answered by saying, okay, we're going to go talk to those patients.
Huh. And is that ongoing, or do you have any results?
We have just started.
Okay.
We have just started. Yeah.
Got it. Let's see. So we're talking about the effect of telemedicine, remote health monitoring. How are they functioning as the newest tools in preventive medicine? We just mentioned how they may kind of alleviate over the burden on seeing many different patients on providers and therefore improve access. Are there any other, how else have telemedicine, remote health monitoring been assisting primary care and preventive medicine?
I mean, the biggest one that I have in mind, and actually I've been reading about the COVID pandemic. During the COVID pandemic, I ran our COVID monitoring program. So this was like thousands of patients who had COVID, and we kind of set up an automated daily questionnaire that they would fill out. But you could easily imagine generalizing that to respiratory complaints. So I sort of mentioned like a failure of triage, but and not that we've pulled this off, but imagine a world where somebody called into the practice and said, "Hey, I need an antibiotic. I have a runny nose." You say, "Okay, let's have you fill out these questions. If it doesn't seem like there are any red flags, don't need to come in. We're going to send you another questionnaire in another day," and you can sort of stay attached to the patient through the course of their illness. Never mind with AI tools kind of potentially making this easier, but I think that's what's coming in the future.
Jeff, we are approaching the end of this podcast episode. And I'd like to kind of pose a final question to you. You mentioned when we were just talking a moment ago about HEDIS measures for inappropriate antibiotic use. And you said that as you see providers go more in line with the gold standard, you're seeing improved provider satisfaction. I know that there's an issue with electronic health records and the increasing complexity of medical practice. You wrote a paper that said for providers, it never gets easier. You just go faster.
Right.
So on that
Greg
topic,
LeMond quote. Yeah.
So on that topic with provider burnout,
yeah.
And on the topic of provider satisfaction, where they're doing the right thing in accordance with the Hippocratic Oath to do no harm, I'd like to ask you if you could reflect upon the positive externalities of reducing antibiotics overuse.
I mean, I think that we touched on some of them. So there's I'm not sure if it's an externality, but maybe in the context of the patient-doctor visit. But yeah, reducing inappropriate antibiotic prescribing, reducing the prevalence of antibiotic-resistant bacteria, fewer costs. Maybe you can prevent these visits, as I alluded to. But the biggest thing by far is adverse drug events. So kind of that happen at a much kind of less severe level, but are much more common. So, somewhere between 15 to 25% of people who get an antibiotic are going to have some kind of adverse reaction to it. If it's a rash, diarrhea, yeast infection, for having gotten an antibiotic that they didn't need in the first place. And I think that is actually kind of the quality imperative, is avoiding adverse drug events from antibiotics.
Perfect. Well, with that, I'd like to thank you for joining us today, Jeff. For our listeners, this has been Dr. Jeff Linder, the Chief of the Division of General Internal Medicine at the Northwestern University Feinberg School of Medicine. Jeff, thank you very much for joining us today.
Thank you so much.